Bismillahirrahmanirrahim. Hello everybody. A 21-year-old woman gravida 1 para 1 at 36 week of gestation is sent to the hospital for a blood pressure of 190 by 110 mm of Hg in the office. The patient was prescribed insulin therapy for gestational diabetes at 28 week of gestation but has been poorly compliant. On arrival, her blood pressure is 184 by 106 mm of Hg. Initial laboratory results show elevated serum creatinine and transaminase. Blood pressure is 204 milligram per deciliter. Urine dialysis show 4 plus protein urea. Nifedipine, magnesium sulfate, and insulin are administered. Induction of labor is started with oxytocin. 6 hours later, the patient blood pressure is 150 by 90. Laboratory results are as follows: calcium 8 milligram per deciliter, glucose 143 milligram per deciliter, and magnesium 9.10 milligram per deciliter. Which of the following is a which of the following is the most likely cause of this patient hypermagnesemia? So this patient has hypermagnesemia. Choice A, drug-drug interaction. Choice B, hepatic insufficiency, hypocalcemia, oxytocin toxicity, renal insufficiency. So here the normal magnesium level is 1.7 to 2.2 milligram per deciliter. This is the normal calcium level, and this patient have hypermagnesemia because her magnesium level is 9.2 milligram per deciliter. So in this question they are asking about that what is the cause of this patient hypermagnesemia. So as we already know that this patient has increased level of creatinine, which means that she having the kidney damage, and second she having increased level of transaminase, from which we are sure that she also having the hepatic injury. So the most common cause of hypermagnesemia in patient with increased creatinine is renal insufficiency. Choice C. So here the correct option is choice C, renal insufficiency. Why the choice E is the correct one? Because magnesium sulfate is the treatment of choice for the prevention of eclamptic seizure. As we already know here that this patient received nifedipine, magnesium sulfate, and insulin. So magnesium sulfate is the treatment option for the prevention of eclamptic seizure. It is also administered to patients for whom preterm delivery is imminent, as it decreases the risk for cerebral palsy and premature infant. Common adverse effects of magnesium sulfate include headache, nausea, fatigue, and diaphoresis. Signs of magnesium toxicity include loss of D10 reflexes, somnolence, and respiratory depression. Because magnesium is solely excreted by the kidney, a common risk factor for magnesium toxicity is renal insufficiency. Patient with an elevated serum creatinine may need a lower magnesium dose and close observation. Calcium gluconate is the first line treatment for magnesium toxicity. So treatment for magnesium toxicity is calcium gluconate for hypermagnesemia. Now come to the incorrect one, drug-drug interaction. So concomitant use of calcium channel blocker, for example nifedipine and magnesium, can potentiate hypotension. This patient is hypertensive, so there is no drug-drug interaction. Choice B, hepatic insufficiency. So although this patient transaminase indicate hepatic damage from preeclampsia, the liver is not involved in magnesium excretion. Choice C, hypocalcemia. Hypocalcemia is a potential adverse effect rather than cause of hypermagnesemia due to temporary suppression of parathyroid hormone secretion. Choice D, oxytocin toxicity. So oxytocin can enhance antidiuretic hormone release and cause the development of the syndrome of inappropriate antidiuretic hormone secretion. Patient with syndrome of inappropriate antidiuretic hormone present with hyponatremia, not hypermagnesemia. So now come again to the choice E. Why the choice E is the correct one, I will explain once again. Because this patient having increased level of creatinine and transaminase, and we administer her nifedipine, magnesium sulfate, and insulin. Magnesium sulfate are administered for the prevention of eclamptic seizure. So this patient already having the kidney damage because our creatinine level are increased. So on such patient we can care about the magnesium level, dosage and prevention of hypermagnesemia. So